معلش, I know it's been a long day. Inshallah, I will try to be as brief and as interesting as possible. First of all, I would like to thank Professor Dr. Amal Bishlawi for inviting me to give this talk. And actually, I chose this topic because though it's quite serious and it can significantly affect the quality of life of women up to being life-threatening, yet it is underdiagnosed and under-recognized, and we really should pay more attention to it. Now, the thing is, we have here one of two scenarios. Either a patient presenting with menorrhagia and not known to have a bleeding tendency, and this can be up to 10%, where only 2% of them are investigated to be diagnosed. The other scenario would be a teenage girl or an adolescent or a woman who has an inherited bleeding disorder and is presenting with menorrhagia at any stage of her life, but usually would be at the beginning or at menarche. So this is the second scenario is going to be the topic of our talk. For those who haven't been to our hospital, this is where our OPC or outpatient clinic for hematology is based, and that for the disorders of bleeding and thrombosis is usually every Sunday, where we get to see new patients or follow up old patients. Unfortunately, we are having most of our junior hematology staff here, so I'm really glad for that. So, the hemostatic system has a central role in controlling the duration of menstrual bleeding. Thus, abnormally prolonged or profuse bleeding does occur in most women affected by inherited bleeding disorder. Menorrhagia, or how I would like to refer to it as heavy menstrual bleeding, is the most common symptom of women with bleeding disorder that women with bleeding disorder can experience, including specifically adolescent females, and that's when we get to see them with inherited bleeding disorder. Actually, the inherited bleeding disorders, and by that I'm referring more to the von Willebrand disease, to the platelet dysfunction disorders, as well as the rare coagulopathies, is quite prevalent in our society, especially the rare coagulation disorders, and it's comprising more than 10%, as was published in 2012 of our cohort. And that, of course, is attributed to consanguineous marriage. Objectively, menorrhagia is defined as bleeding that lasts for more than 7 days or results in the loss of more than 80 mL of blood per menstrual cycle. The prevalence of menorrhagia ranges from, sorry, the slide is not, yes, because not the whole slide is apparent. Okay. Just, can you, yes, I need to minimize that. No. Can you minimize that slide? This is more than 100%. Sorry about that. Okay. Yes, please. Okay. Shabas, I'm not used to your laptop. Okay. Okay. Okay, that's better. Thank you. So, the prevalence of menorrhagia in a woman with a bleeding disorder would range from 32 to 100% in patients with von Willebrand disease, to 5 to 98% in those with platelet dysfunction, and 35 to 70% in women with a rare coagulation disorder. Now, the treatment options are similar to those for menorrhagia in general, and that would include tranexamic acid, the combined oral contraceptives, and the levonorgestrel intrauterine system, which is usually first tried. In case of failure or contraindication, before considering surgical options. Now, it's very important to highlight here that oral contraceptive pills and the intrauterine system loop, or what we refer to as LNG-IUS, is usually not the preferred option in adolescents. Also, we have not to forget about the desmopressin, especially in von Willebrand disease, and replacement therapy, and very importantly, the exclusion of non-steroidal anti-inflammatory drugs. Now, as heavy menstrual bleeding is an overlooked problem in spite of its negative impact on the quality of life of those patients, with few studies reported in Africa, including Egypt, nonetheless in adolescent girls, in whom it's particularly distressing because of their delicate emotional equilibrium. So, we assessed the prevalence, severity, characteristics of heavy menstrual bleeding and its impact on the quality of life of our adolescent cohort with inherited bleeding disorders before and after therapy. And you will see now in the patients and methods the therapy that they received. It's usually what is received in other parts of the world, other than the desmopressin. So, our study is a retrospective review of the medical records of 32 adolescent girls with a diagnosed inherited bleeding disorder following in Cairo University Pediatric Hematology Outpatient Clinic and attending the multidisciplinary clinic for menorrhagia, and that would usually be monthly, usually on a Saturday. Assessment included a detailed menstrual history and bleeding history on presentation. Okay, thank you. So, our initial assessment including detailed menstrual history and a bleeding history on presentation, as you can see here on the right-hand corner, using the ISTH-BAT, which is now the standard for assessing bleeding. Menorrhagia was evaluated pre and post-treatment, and that's very important, using the pectoral blood assessment chart, as you see here, and we usually used, of course, the pads and the blood clots. We usually don't use the tampon part. As well as assessing the quality of life using a questionnaire designed by Kadir et al., which is very important, and it was tailored to our cohort. And that also was assessed pre and post-treatment. Menorrhagia was considered severe if associated with cardiovascular instability, clinical anemia, passage of menstrual clots or flooding, use of more than 10 pads per day. Patients are followed up regularly every 1 to 6 months according to the severity of the condition, and each patient has an individualized treatment plan, and they would have records, and they would come with their records, because this is very important. It determines their short-term and long-term plan. Gynecological assessment included a routine pelvic abdominal ultrasound to exclude any underlying pathology and to exclude other complications as hemorrhagic ovarian masses and cysts, of course. Treatment included tranexamic acid as first line, and as you see here, I just put the photo of tranexamic acid, whether oral or injection, because this is a very important first line and it really makes a difference. Or oral contraceptive pills if indicated, iron therapy, replacement therapy according to the condition, and blood transfusion if and when indicated. Then statistical analysis of all collected data was conducted. Now, very interestingly, 50.8% with a mean age of 16.6 plus or minus 3.6 teenagers diagnosed with inherited bleeding disorder had menorrhagia. The commonest, as expected, is von Willebrand disease, accounting for 66.7%, followed by, very interestingly, the rare coagulation disorders, and actually a quarter of these are due to fibrinogen disorders, because if you see in the study we published that fibrinogen disorders in Egypt are the most common rare coagulopathy, followed by factor 7, not like elsewhere in the world where factor 7 is the commonest. And the platelet function disorders, they come last in order, and usually it's Glanzmann's rather than Bernard-Soulier. All our patients were nulliparous except 2. One had factor 5 deficiency and one had von Willebrand disease. And 2 afibrinogenemic patients unfortunately had repeated abortions. The thing is that patients keep following it with us as outpatients after their 20s. Menorrhagia was the event that led to diagnosis in around 20%. The mean initial ISTH-BAT is 18 plus or minus 9.2 before treatment. Now, 77.4% received tranexamic acid with oral or IV, 41.9% oral contraceptive pills, whereas 53.1% received both. If you would like this, these results, and this was presented as a poster and an oral presentation in the previous ISTH, if you would like to look afterwards. The mean age at menorrhagia was 12.5 years, and 81.3% had a positive family history of a similar condition, and 51.6% were of consanguineous marriage. Now, as you can see here, treatment really made wonders, including tranexamic acid. So, regarding pre and post-treatment comparisons, The cycle frequency was less, the duration less, and very importantly, the regularity became regular in more than 50% of those patients, even the frequency of changing the sanitary napkins, and as well as the dysmenorrhea score, because if you have severe bleeding with the spasms, so it can lead to severe dysmenorrhea, and absenteeism from school, and that really made wonders for our adolescent girls. Now, as you can see here, this is very important. This is the pectoral blood assessment score, where you can see here that it ranged from 1,050 to 1,800, with a median of 1,450 pre-treatment, where post-treatment it dropped to 170 to 720, with a median of 360. And that was statistically significant, with a p-value less than 0.01. Same thing for the quality of life. It really improved after treatment. Pre-treatment, it was 21.4, plus or minus 7.3, and post-treatment, it was 33.1, plus or minus 12.1. And that was, again, very statistically significant, with a p-value of 0.01%. Now, regarding complications, that's really a slide that I need to just pause at, because that is a very sad slide. Now, 3 patients had rupture ovarian cyst, 1 died, 1 living, and 1 did an oophorectomy. 1 had a bilateral oophorectomy, and I remember this very well. This patient had factor V deficiency, and at the age of 18, actually she presented with severe acute abdomen, bilateral ovarian cyst, and rupture, and unfortunately she did total hysterectomy, bilateral oophorectomy at such a young age, and this was catastrophic for her. Another one is our patient, and you will see her picture at the last slide. This is a 15-year-old, again, with factor V deficiency, who presented with retinal hemorrhage. She was doing so well. Teenage period, she developed menorrhagia, and it was more or less controlled. And then one of her, at one time, she had a rupture ovarian cyst, and unfortunately, on her way to hospital, we lost her. Okay, so 56.2 of our studied cohort required hospital admissions, with 64.5 requiring blood transfusion. Very interestingly, the mean hemoglobin pre-treatment was 7.4 plus or minus 2, while post-treatment it was 10.7 plus or minus 1.1, and that really correlated well with the pectoral bleeding assessment tool. In conclusion, menorrhagia is a common symptom in Egyptian adolescents with inherited bleeding disorder, most commonly due to von Willebrand disease, followed by fibrinogen disorders. Menorrhagia is usually severe, affecting quality of life significantly, yet all parameters, the bleeding assessment, the pectoral bleeding assessment tool, the menstrual characteristics, the hemoglobin level, all showed improvement on treatment. And that was statistically significant improvement on the quality of life of patients. Now, this is our thank you slide. This is very important. Unfortunately, this is the factor V patient that we lost. This is one of our patients with platelet dysfunction. And these are 3 patients on prophylaxis, and they are doing well, 2 with von Willebrand disease and 1 with factor VII deficiency. Now, this was during one of the wonderful celebrations of Dr. Magy of the Egyptian Society of Hemophilia, and the children were so happy. Unfortunately, this is the current picture, but inshallah, they got a new picture there. And I would like to thank so much our patients and their families, our research fellow, Dr. Omneya, and our gynae consultant, Dr. Ahmed Zakaria, and our hematology team, especially those looking after the disorders of hemostasis. And actually, we are having all the junior staff here, but we don't have any of the senior staff. But thank you to everyone, and thank you.
Thank you, Dr. Magy, for this elegant presentation. But I would like to ask you, there weren't any hemophilia carriers among your patients with menorrhagia?
Actually, no. The thing is that hemophilia carriers, they don't follow up regularly unless they have a major problem. So none of the cohort, and
none of them
backwards,
suffered menorrhagia?
There was only one that had menorrhagia, and she had to do a surgical intervention, and after that we lost her. But otherwise, none of them had, which is it's an important and interesting question, because this is contrary to the results worldwide, really.
Yes. Thank you so much.
You're welcome.
So, any questions to Dr. Magy? Yeah, تفضلي.
Adolf, for this very interesting session, and thank you very much that you invite the Women's Federation of Hemophilia, which is really very important. At the end, في الآخر بحب أشكركم جميعا لحضور المؤتمر رغم صعوبة الموقف على مستوى العالم، مش على مستوى مصر، وكوفيد ومش كوفيد، و all the hazards which can be. يعني أرجو إن برضو حكاية الماسك، في دكتورة شايفاها، كذا دكتورة شايفاها من غير ماسك. يا جماعة الماسك والحاجات الاحترازية دي very important. لازم نخلي بالنا منها عشان ما يحصلش فيه أي سبريد، لأن اليومين دول very strong، والسبريد very common. فمن فضلكم يعني تباركوا مش بس أثناء المؤتمر، بعد المؤتمر. وبشكركم، بنتمنى إن شاء الله بإذن الله الساجة نشوفكم. بشكر التيم الجميل اللي معانا، الكوردينيتورز، دكتورة سمية جوهري، دكتور خالد ده بطل من الأبطال الجوشيه ديزيز، دكتورة رانيا، دكتورة منى غمراوي، كل دول ناس ليهم أيادي بيضاء على المؤتمر ونجاح المؤتمر. وكل سنة وانتم طيبين. في غدا ولا فيش؟
في، بس احنا نقول لهم على القاش.
وبعدين في حاجة كويسة، معلومة مهمة جدا، ان جمعية امراض الدم وابحاثه بقينا ممبر في البيست اوف اش اللي جاي ان شاء الله في مارس اللي جاي ده، هيبقى عندنا بيست اوف اش في مصر. احنا جمعية امراض الدم وابحاثه هي المسؤولة عنه. زي بالظبط بس فيها كنا 3 سنين 17 18 19 كنا شركاء مع الايها بين هيماتولوجي اسوسيشن، وجم هنا وعملوا عملوا كونفرنس، وبالتالي في اكيد جزء منكم كان حضر الكونفرنس ده. المره دي بقى الامريكان سوسايتي اوف هيماتولوجي اللي جاي ان شاء الله في مارس، واحنا هنبقى جمعيه امراض الدم وابحاثه شريكه في هذا المؤتمر. طبعا هيبقى فيرتشوال، مش هيبقى زي ما احنا قاعدين كده، ففيرتشوال بس هنسمع الجديد في العلم، هنسمع كلام كويس قوي مهم قوي من ناس مهمين خالص. وكل سنه وانتم طيبين.
شكرا رئيس الجامعه.
يلا. لا